All right, welcome everybody. Welcome to the first virtual San Francisco Surgical Society meeting. In these difficult times, we're sort of adjusting and accommodating, and I certainly didn't want to miss another meeting. So I think we have an excellent setup today with some fantastic speakers, and I really appreciate we have, it looks like right now, about a little over 40 people signed up. Dr. Zach, do you want to introduce the first participant?
Absolutely. So good evening, everyone. Happy to be with you here today. And we have a great lineup of panelists. We're very glad to have Dr. Janice Louie to start with us today. Dr. Janice Louie, in normal times, is the medical director of the San Francisco Department of Public Health Tuberculosis Clinic. For the last 105 days, she has been activated to be part of the clinical response to COVID-19. She's currently the lead managing outbreaks in San Francisco skilled nursing facilities. Her background training is in adult medicine at UC San Diego and infectious diseases at UC San Francisco. Before coming to the TB clinic, she worked for 12 years at the California Department of Public Health, leading statewide influenza surveillance. She's also been part of outbreak responses at the state level to SARS, MERS, Ebola, and the last pandemic, H1N1. And today she has graciously agreed to give us an update on the COVID-19 situation in San Francisco. Dr. Louie.
Thank you. Okay, so I'm going to share screen. And get rid of, I'm not sure how to get rid of, oh, I see here, get rid of the poll.
Is the poll blocking your screen there?
I got rid of it. Now I just want to, can you see my screen?
Yes.
Okay, great. All right, and let me just make sure. Okay, great. Okay, so I'm here to give an update about what's happening in San Francisco. And can everyone hear me okay? Dr. Melcher, can you hear me okay?
Yes, yes, I can.
Okay, all right. As was mentioned, I'm the lead for outbreaks in skilled nursing facilities, but have been there from the beginning, so have watched the evolution of this. And I'm just gonna be the intro to Dr. Rutherford is gonna talk on a more broader scale about the public health response. So this is what's happening in the state. And so the things I just wanted to point out are that in general, as far as infections, let me get rid of this here, 75% of cases, let's look at age first, are in young, healthy adults, or presumably healthy, but age 18 to 64, with the race ethnicity predominance of Latinx. So 50%. Near half of the infections known, and that's skewed data, we'll talk about that. About a quarter are white, and about an eighth are Asian. And I just wanted to point out, here are known positives, and here are known deaths. Oops, let's get rid of this.
Sorry about that.
That's okay. And so the case fatality rate is around 4.2%. That's actually fairly high, but remember, our testing is very skewed. And San Francisco is number 8. So if you look at this kind of circle of density, really LA is where it's happening. And then the Bay Area with Santa Clara being high, San Francisco, Alameda, the whole cluster in the Bay Area. So our populated areas are where we're identifying COVID, but that may be because we have a lot more testing happening. So let's see where we go as far as sharing slides. Let's see. Down here, maybe?
Yeah, or just double click on the page with your yeah.
Okay, yeah, just there's a light. So these are the relevant, there have been many, many health officer orders. I just wanted to point out the big ones, which is on March 6th, there was a declaration of a local health emergency, and that freed up a lot of funds for us from emergency preparedness in order to start to really marshal efforts, draw on personnel, draw on PPE caches, and really ramp up response. So that was actually a fairly early important public health order. And then on the 12th of March, we locked down our skilled nursing facilities because there was data beginning to emerge that this was the most vulnerable population. And then of big relevance is on the 16th, we had a shelter in place, which is still in existence. And then on the 18th, we had a moratorium on routine medical appointments and elective surgery. So that really brought down the volume as far as primary care and elective surgery procedures. And then on the 17th, we had a universal masking. And so we had very much of an early response as far as I think we were lucky in that we were definitely not obviously the first place to see COVID. And we could model our response based on successes and failures of other places. So as you can see here, these are reported cases in San Francisco, and we've had only 31 deaths and 1,728 cases that are confirmed. We know there are many more that are likely unconfirmed. But what I want to point out is not only is there a low death rate, I think the mortality rate is 1.8 compared to what I said at the state was in the 4 range, but also you see that this curve seems to be really flattening out. So whether that's sustainable or not, we don't know as things open up. But San Francisco, it appears, and what they say in the news, has done a pretty good job of mitigating morbidity and mortality. Okay, so I just wanted to compare a little bit as far as the age and the race ethnicity. So there have been a lot of surprises, have not been, sorry. So here in San Francisco, this is just, I want to point out that in 2018, this is the age distribution of our city, and seniors comprise about 25% of COVID cases, but only about 17% of our population. So clearly we're skewing more toward the elderly as far as relative to the San Francisco population. But again, as I noted, overall, this may be a testing bias, we're not sure. Adults age 18 to 60 make up the bulk of infection, but we definitely have a higher proportion of elderly. These are comparable to the state numbers. And again, I think it's relevant to point out that either we are not testing a lot of children, or it is not occurring a lot in children. It's probably the former and not the latter, because we know, for example, with influenza, that children are the major vehicle for transmission. So as far as race ethnicity, oh, sorry about that. That's my daughter's phone. So we have Latinos comprise about 15% of the San Francisco population. Let me find my cursor over here. But they make up about 36% of COVID infections diagnosed. And this is the same trend statewide. The other proportions are relatively similar to what we have in San Francisco. Asians are actually a little bit underrepresented. And this is actually somewhat interesting in that other data has shown that there's perhaps a larger proportion of Hispanics infected because they also may comprise most of our essential worker workforce who either don't have sick leave or are unable to shelter in place because they can't afford to. So there's a lot of theories about why this is happening, and maybe George can comment more on that. Definitely in our healthcare worker population in the skilled nursing facilities, we see that major force, the nursing aides, housekeeping, there are a few RNs in skilled nursing. Most of them have to work, and most of them are either Hispanic or Asian Pacific Islander. So this is just the laboratory testing picture. So again, just remember this is skewed because in the beginning, and the beginning is before even this curve starts, this last 5 weeks, we had very limited testing available. So we only tested hospitalized patients initially. And in fact, initially it was only severely ill, ICU, and then hospitalized with pneumonia. So the overall rate in persons who had, let's say, symptomatic infection was about 8%. But as we broaden to start testing more asymptomatic populations, which the world and San Francisco are doing, hopefully we'll see that proportion go down. So this is more a reflection of our testing capacity than it really is of the actual proportion that are positive in San Francisco. So I want to talk a little bit about mortality because this is what we do in public health. And so again, this is not outside of what we've been seeing everywhere else, which is that a large proportion of our deaths are in the elderly, relative to only comprising about 17% of San Francisco. they make up the majority, almost over 90% of our deaths. So it's interesting that this is very different from influenza in that that's more of a U-shaped curve where we see deaths and or severe illness in both the very young and the very old. And from an ID standpoint, it's a little unclear to why children are not getting sick from COVID-19 in the classic way of sepsis and death. And it probably or maybe has to do something with the different kind of immune response that is generated. We think that like flu, a lot of the severe illness is due to a cytokine storm type of immune response. And there just may be a different kind of immune mechanism in children. It's really yet to be identified what's happening. We saw the same thing with the other other coronaviruses like SARS and MERS. That doesn't mean to say that children are not an important population to watch, because again, the under 5 are likely vectors of transmission. And often what we find from a public health standpoint is when you shelter in place and close schools, but you still have people working, it's the elderly that are taking care of the young children. And so we just have to be very cognizant of that when we start to open up and go back to work. So here's the race ethnicity for deaths. And I think what's interesting in San Francisco, unlike in California, is that we are seeing a skewed rate of mortality with Asian Pacific Islanders. So our numbers are very small. There's not a lot to make of it. And I'm actually not quite sure why we have this skew, but maybe larger numbers will help us understand this discrepancy. And then just to remind everyone, we already know this, that 97% of our deaths have had chronic underlying illnesses. And it's very hard to tease out if you are older and you have concurrent heart disease or hypertension or diabetes or chronic lung disease, what's contributing to what. But we do know that the two go together as one ages, and so we're seeing that in our deaths. 30% of our deaths are occurring in skilled nursing facilities, which I'll touch on. And then I just thought I would show everyone for interest. We also monitor, this is on our website, the number of beds available. And so San Francisco has 1,300 acute hospital care beds and 200 ICU beds. And so we do actually have a lot of beds available. Sorry, our capacity is 900, we have 1,300 acute beds and 426 beds now, and our capacity is actually expanded from what it was before. So we have a lot of beds available is the gist. We also try to house vulnerable populations. So this is actually a statewide effort. And essentially what it is as hotels have emptied, the city has contracted with many different hotels to open up rooms for vulnerable populations. And so this includes being homeless or living in a congregate setting like an SRO or a board and care, an assisted living. Also, if you are a healthcare worker or other essential worker who cannot safely stay in a home and isolate from your family, priority is given to those who are elderly or with comorbidities. And we actually have on our website a housing kind of monitor, which tells us how many beds are occupied or not. We have a whole branch in our response unit that its sole job is to place vulnerable populations in hotel units. And actually some of these are quite nice, like the Marriott. The Mark Hopkins has been housing some homeless people. So if you're motivated, you might end up in quite a nice setting for a while. This is our summary list that we put out daily of outbreaks in congregate settings. And so I just wanted to show you that there are many, many outbreaks happening. We have 27 as of yesterday. These are occurring again, as you can see, SROs, skilled nursing facilities, boarding cares. And in fact, this one made the news at the MSC South Homeless Shelter, where they tested 176 residents and 106 were positive. So that infection rate was 60%. And a majority of those were asymptomatic. So what we think, again, this shows that there's a big discrepancy as far as who is getting infected. It's probably those who cannot shelter well in place. And our shelters are quite crowded. The beds are not spaced 6 feet apart. There's a lot of congregate milling, and these are open shelters. So in the daytime, these residents go out and about and probably congregate in other ways. And so it's been very hard to control transmission in this type of setting. 60% is pretty big. So likewise, we are very worried about our skilled nursing facilities because this is where mortality is happening. So as of yesterday, there were 11 outbreaks in skilled nursing facilities, including half of the infections were occurring in staff. So the SNFs have been in lockdown since March 12th. And so in theory, the patients are not the ones who are being the index case, it's the health workers coming in. And what we're finding is that healthcare workers, and again, these are usually low paid, without a lot of sick leave, are working at multiple facilities where there are outbreaks happening. And so they are bringing the infection into other places. We have around 25% of our residents end up being hospitalized who are in SNFs. And of those who are hospitalized, about half are dying. So whether that death is due to COVID or is due to another cause, we don't know, because we call anyone who has died who has COVID infection a COVID-related death. So those numbers may be skewed high, but it does remain that 30% of our overall mortality is in skilled nursing facility residents. So this made the news. This was Central Gardens. It's one of our SNFs in San Francisco. And we actually have been doing mass testing in response to identification of a few cases in a skilled nursing facility. And what's been surprising, well, maybe not really, because it's also been reported in Seattle in their big outbreak, is in this facility, we tested facility-wide, and 42% of staff and residents who were asymptomatic tested positive. We also tested another facility recently, and 68% of residents on that floor were positive. So this supports what CDC has also reported, which is that there is a lot of asymptomatic transmission occurring, particularly in these congregate closed settings where these elderly residents are very dependent on probably infected healthcare workers who have very close contact, helping them perform ADLs, dressing, bathing, changing their sheets, etc. We've actually had to come up with a way to get healthcare personnel back to work in SNFs, because the other problem we've had is that there's a high vacancy rate. So there's still a lot of hysteria about COVID-19, and most facilities do not want to be in the news. When they are in the news or when there is an outbreak, most healthcare workers who are not paid highly will tend to report in sick, even if they're not really sick. So we've actually had to make an algorithm where if you test positive, but you're asymptomatic, you can return to work and care only for COVID positive patients, as long as they're non-immunocompromised, and as long as you don't share a bathroom or break room with COVID negative staff. So it's been a big effort, and we really have had to think out of the box as far as how to maintain staffing in these particular healthcare facilities, and to ensure that they're still operating, because many of them are already on the kind of financial edge of maintaining services. So we've really had to be more pragmatic. And I think the context of this in general is that the way we've approached COVID is very different from how we've approached influenza. It's been studied, I think, more than any other virus possible. So now that we have molecular testing, we know where this virus is, but what we don't know with PCR is whether it's dead or a live virus. And so because COVID is a select agent, you can't really grow it anywhere. You need a BSL-3 lab, which are not very common. So we're relying on PCR, and we're making up a lot of algorithms to protect everyone. But I think what we may be losing sight of is whether this is actually a viable virus or not. So it's been very challenging to work with this unknown, as far as we know it's everywhere, we know it's on every surface, but that may be the same for many viruses, and we've just never looked at it in such detail before. So my last slide is just, we are awaiting a public health order, which is probably coming this week, where again, we've never done this before, but we are going to be doing mass testing of all nursing homes in San Francisco. We're following suit in other cities where they're seeing lots of mortality in nursing home residents and recognizing the problem. And so we will be testing, I think the number is 2,500 patients and over 3,000 staff in a mass effort, and then repeating the staff every 2 weeks. As long as the nursing homes stay closed, we think this may decrease mortality, but we'll have to watch it over time. So it's all kind of a not very comforting evidence-based actions we're doing, but I think maybe this has given you kind of an example of where we're at as far as how we're trying to move forward and protect everyone, but also support being pragmatic as far as how we address these public health measures. So I'm going to stop there. Let me see if I can unshare my screen. And I'm going to leave it back to Dr. Melcher.
Yes, thank you very much. I think what we're going to do is we're going to save questions for the end when we have the whole panel on board and they can all participate in the questions. I just want to report quickly the results from that first poll. So of about 90% of you took the poll and 41% have been tested. No one has been positive of the people who answered the survey, and about 10% of the people who answered the survey have cared for positive patients. So it sounds like a lot of the healthcare workers, at least in the hospitals and stuff, have been relatively safe. Yulia, do you want to present Dr. Rutherford then?
Absolutely. So we have the pleasure of having Dr. George Rutherford here with us today. He's the Salvatore Pablo Lucia Professor of Epidemiology, Preventive Medicine, Pediatrics, and History, and the head of Division of Infectious Disease and Global Epidemiology in the Department of Epidemiology and Biostatistics at UCSF. Educated at Stanford University and Duke University School of Medicine, he's board certified in pediatrics and general preventive medicine and public health. His expertise is in the epidemiology and control of communicable diseases of public health significance, with a focus on HIV, Ebola virus, and the Zika virus infection in low and middle income countries. And he has been involved in the public health response to COVID since the earliest days of the pandemic. He will talk to us today about the history, explosive epidemiology, and prevention of COVID-19. Thanks, Dr. Rutherford.
Thanks so much. So my best surgical story you should know is that having gone to Duke to medical school, David Sabiston wrote a letter for me for a pediatric internship. So I think that's my claim to fame with surgery. So let me walk you through these. Through this, I'm going to talk about kind of the big picture of this. This is a shot of Wuhan, China, which was where the virus first emerged. So I want to talk a little bit about a bunch of different stuff, but mostly focus on epidemiology and also on some of the prevention issues. This is the guy. So this is this cartoon down here on the lower left. This is the coronavirus that we're talking about, which is called severe acute respiratory syndrome coronavirus 2, or SARS-CoV-2. It has it's a very large RNA virus that actually has the ability to repair its genome, which is one of the reasons we don't see a lot of mutation in this. On its surface, it has these spike proteins, which makes it look like a crown, hence the name corona. And it binds these S proteins, specifically this binding domain here, bind to the ACE2 receptors, which are in lung alveolar cells, upper airway epithelium, and glandular cells of the GI tract. Now, just to throw in a little virology here, these are closely SARS-CoV-2 and the original SARS, severe acute respiratory syndrome, from 2002-2003 are closely related. They're part of this whole bat lineage, these guys here. of coronaviruses that can be transmitted to humans. The original SARS, and there's a third one called Middle East Respiratory Syndrome, or MERS, which is somewhat more distantly related, but still sort of part of this kind of overall group of beta coronaviruses. And I can talk more about this if you'd like. All the coronaviruses have had an intermediate host that have an accidental intermediate host, which have led to the infection of humans. For SARS, for the original SARS, it was an animal called a Himalayan palm civet, which is like the size of a cat. It looks kind of like a raccoon. For MERS, it's a dromedary, which is like a camel but plus one hump. And for SARS-CoV-2, it's this guy, which it was called a pangolin. Pangolins are mammals. It doesn't look much like a mammal here, I agree. And they have these kind of like thumbnail keratinized scales on them, kind of like an armadillo. And these are used, the scales from these guys are heavily used in traditional medicine. So currently, the original outbreak was in Wuhan, China, which is here in central China. And think of it as sort of the St. Louis of China. It's on the Yangtze River. It's probably 500 miles inland, maybe 300 miles inland from Shanghai. And it's a major transportation hub in China. A city of 11 million people. It's in the province of Hubei, Hubei, which has a population of about 59 million. So from that outbreak, the disease spread through China, but still mostly concentrated in Hubei, a little bit to Korea and Japan, a little bit to Southeast Asia, but really mostly to Iran, and from Iran around the Persian Gulf and to Europe, to Southern Europe, with major foci in Iran, in Italy, and Spain initially, and then spread to the eastern United States with huge foci down the eastern seaboard, starting in Boston and going all the way down and through Washington, D.C. Currently, and the West Coast was actually seeded primarily from Asia. So currently, the U.S. has about a third of all cases in the world, and 4 to 5 times more than the largest caseload in the next biggest country, which is Spain. We also have almost a quarter of all deaths in the world, and the number of deaths in the U.S. are more than twice as high as in these other countries, the UK, Italy, Spain, and France. And you'd have to go way, way down this list to get to China, by the way. So this gives you a little bit more idea of the epidemiology of COVID-19 deaths and cases and deaths by day of report. In the US, this pink guy over here on the left is the number of cases per day. And you can see there was a rapid rise, which basically coincided with the outbreak in New York. And then rather than falling off, this is across the entire nation, there have been another number of other outbreaks which have pushed
Hello? Looks like we lost audio. Let me see. All right, sorry for technical difficulties. Hopefully Dr. Rutherford will log back on. Looks like he logged off. While we're waiting, I'm going to launch a second poll. And have you guys answer this poll while we're waiting for Dr. Rutherford to log back on. In fact, if anybody has any questions for Dr. Louie, we can also talk about those. I think the best way to do that is for someone to raise their hand. If they want to say anything, I can unmute you and should be able to talk. Dr. Louie, can you unmute yourself? And there are a couple of questions that people have for you.
Yes. Can you hear me?
Yes.
I cannot see the questions.
Right. Somebody's asking about the different types of testing being done. Can you just quickly go through those?
Yeah. So at our public health lab, in most labs, it is only PCR. You know, I know there's a lot of discussion about serology out there. None of them are, at least let me talk from an ID standpoint. We are not sure what they mean. So I think everyone saw that there was a study in the Mission where 2% roughly were positive, but no one is sure what to make of that. And in general, if you look at coronaviruses overall, there's not been a lot of success with a long-lasting vaccine. It's thought that natural immunity lasts maybe a few months to a year, and the vaccines have not been successful as far as SARS and MERS. So as far as using serology, that has not been a big push just because of our experience with other coronaviruses and how to measure immunity. So while there are many, many commercial tests out there, there was that political push in the beginning to have a lot of testing, and the FDA has been slow to approve the test, but yet they have allowed them to be offered with kind of a 14-day process to review any results that come in after that test is put out. So it's been a very backward process. And at the present time, I think most of us doubt, we don't know how to interpret all these different serologies coming out and what they mean, I think is the gist of it. There's been a lot of kind of doubt about how to interpret them.
Great. Dr. Narayan from one of the Stanford residents wanted to hear about your journey to go into the public health work.
Oh, well, how kind. So I was originally started in public health with SARS, and I am an ID trained person. So that actually Dr. Rutherford steered me in that direction because he said, well, you need to have a salary that's stable, right? So he steered me away from academics. And ever since then, I've been first at the state leading influenza surveillance. And then I worked on other respiratory virus outbreaks as mentioned in my intro. I did SARS, I did MERS, I worked on Ebola. So my pathway has just been moving in different public health emergencies. And then I moved to tuberculosis to get back into clinical care. But it's helped me as far as knowing PPE pretty well. So that's been useful.
Yeah, two topics that Dr. Forrester will speak about at the end
Yes,
here.
can't wait.
And then one last question, and maybe we'll move on to Joe's talk if we don't get Dr. Rutherford back on. Dr. Wapner from Stanford is asking whether or not the contacts of infected healthcare workers are being tested. So
yes, so this
first degree contacts, I guess.
Yeah, this is a big debate actually as far as how far do we go with contact tracing once you have community transmission. So right now, San Francisco is being very aggressive and testing, actually screening first for symptoms, monitoring, and then testing all contacts. And now there was a recent health order to test all asymptomatic health workers. So once you start mass testing, you move away from testing contacts because you're testing everybody. But again, the usefulness of contact investigation with community transmission, I think, is yet to be determined. I see Dr. Rutherford's back, so I hope that helps answer the question.
Sorry, I needed
Excellent.
Janice's teenager to save me. My apologies.
No problem. We got some
Where
good
did we
questions
cut
in while
off?
you're gone.
Where did we end this this magical mystery tour?
You kind of
Did you hear about the
froze.
pangolin?
Yes, we did hear about that.
Okay,
And,
good. Okay, I know where to start then. Sorry.
Yep.
Uh,
I can end the poll. Let me just let people see the results of the poll quickly. It looks like in most cases it reduced everybody's volume by more than 50%. About half of us know somebody that's been infected. I know a healthcare worker that's been infected. And a third of us know somebody who's been infected and actually hospitalized. So some serious impact there.
so this
All
is
right, it's
about
all
right.
you.
Mark, does this look about right?
Yes,
Have I got
yes.
up? Okay.
Yep.
So in the U.S., there's this original rapid uptick, which was really associated with transmission in and around New York City. And I'm sure you've all heard the horror stories from the ICUs there. The reason it's flattened out here is that there have been a number of other outbreaks around in the east and south that have led to this kind of appears to be a plateau. And similarly, deaths, similar things happened with deaths. The White House managed to get this document leaked on Monday. It was published in the New York Times, so I felt it was fair game. And this is looking at projections through June 1st. Now, our projections kind of go up and down, and we hover around no cases kind of through this period of time, out around June 1st. But nationally, the projections are that there'll be 200,000 new cases per day by June 1st. And these are going to be in places that probably are largely in the South and Midwest that have not done a sufficiently good job of sheltering in place. And similarly, the death projection is 3,000 deaths per day by June 1st, 3,000 deaths per day. That means in 30 days, there'll be more deaths from COVID in 1 month than there were in among Americans in the Korean and Vietnam wars combined. And I can't believe they actually published this. Well, this was pirated, of course, but the actual numbers are about 10 times higher than the projections. So, I mean, we got a lot to worry about here. Now, what are we trying to avoid? We're trying to avoid this spike. This is the 1919 influenza pandemic, where the mortality rate was approaching 1% of the US population. So to avoid that, we have two strategic goals. One is to limit new cases by decreasing the effective reproductive number. Now, this is a concept in epidemiology. I'll show you a graph in a second, but it means for each case, how many secondary cases are there? If it's more than one, the epidemic will continue to spread. If it's less than one, the epidemic will gradually extinguish. And so we've been trying to artificially suppress that to below one. And so in the popular parlance, this is about flattening the curve. Now, the person who came up with the term flattening the curve probably got an F in calculus because it's not the same area under the curve. There are actually many fewer cases. And I'll show you an example of that in a second. But the reason we want to flatten it is because we'll have enough healthcare resources available and to buy times for antivirals and eventually vaccine. This is what goes into the effective reproductive number, the number of contacts per day, the probability of infection per contact, the infectious period, how long they're infectious, right? And what's the population susceptibility. And you can see down here the various pieces that feed into that. Now, this is the effective reproductive number from JAMA. So if it's effective, the RT is 1, there's one person infected, that person infects one person, that person infects one person, it remains flat. If the RT is 4, and it was really probably about 3.86 in Wuhan before they went to their version of shelter in place. This one guy infects 4, these 4 guys each affect 4 more, each of these guys each affect 4 more. So you can see how that grows. Now you hear a lot about herd immunity. This graph just shows you what happened in Wuhan in terms of this effective reproductive number over time. Now you hear a lot about herd immunity. Herd immunity is the effective reproductive number minus 1 divided by the effective reproductive number. So if the RE is 4, the herd immunity is 75%. If the RE is 3, herd immunity is 67%. So the problem is there's really no such thing as herd immunity here because we're not sure who is immune and who is not immune. So think of these aren't as bad as antibodies for HIV, which is how we measure past HIV infection or current HIV infection. But probably something on the order of 30% of people who recover from clinical illness have no neutralizing antibody, which is what you need to have to be protective. 30% have tons. Those are the people we're sending for convalescent plasmapheresis, that we can use immune plasma in the ICUs for people with ARDS. And the ones in the middle, they have a little bit, not a lot. It's not clear how long it's going to last. It's not clear how amnestic those responses are, whether they'll get a bump each time they get re-exposed. So this is work in progress. And if you look at R-naughts from Europe, we're much closer to Norway than we are to Spain. This line here is the horizontal line. It represents 1. And you can see as gradual different interventions went into place, it was finally the lockdown that pushed the R-naught below 1. Whereas in Spain, it still hasn't worked very well. And that's because people are out and about. So is it working in San Francisco? Now, this is my favorite slide. I couldn't resist this. You know, at the end of, so this is a San Francisco joke. At the end of April, the Giants hadn't lost a single game and the Dodgers were winless, right? So this is kind of my version of this. So you can see how suppressed the curve is in San Francisco when you put it on this scale. Whereas in Los Angeles, you can see that all these cases that have been occurring, these are thousands of cases a day in Los Angeles County. They went to shelter in place later. This kind of early rise was probably the effect of going to shelter in place later. They went 4 days later, but they also had a weekend and it didn't really kind of click until Monday. So they almost had 7 days or 6 days later to go to shelter in place. And that represented this kind of initial rise here. And then we started to fall. And then they started to get outbreaks in the homeless and in nursing homes and a variety of places with a ton of extra transmission. So for San Francisco, what does the immediate future hold? There'll be a long tail of cases into the early to mid-summer. There'll be occasional outbreaks in congregate living facilities. And identifying and suppressing these will be the biggest challenge this summer. So we're talking a lot about contact tracing, but a part of contact tracing is recognizing and getting on these outbreaks very quickly. There's also the very real possibility that there'll be a very large second wave when children return to school. But there are some data that make me at least mildly suspicious that this is not as transmissible in children as we think it might be. I can talk more about that in Q&A. These were the slides that the state health officer, Dr. Angel, showed on Monday after the governor's speech. When the governor talks about 4 stages, I thought it was worthwhile to put out exactly what those stages are. We're currently kind of winding down stage 1, moving into stage 2. Stage 2 is to reopen lower risk workplaces, and along with modified school programs and more child care. Stage 3 moves to higher risk workplaces, and stage 4 is the end of the stay-at-home order. And one of the things that the governor thinks needs to be in place are therapeutics. And remdesivir is okay, but we probably need something better than that to move forward here. Lower risk workplaces are things like retail with curbside pickup. So you do the shopping online, you phone it in, you go by the store and they hand it to you. I live in Piedmont and in Oakland and Montclair. There are a number of stores, the bookstores, the toy stores and stuff that are preparing for curbside pickup. Manufacturing will go back. As you may know, construction went back this Monday. Offices where telework is not possible will go back. and more public spaces will open very, very gradually. And again, don't think of this as don't think of it as people working at some high-end law firm, with tower at 101 California. Think of it as the guy standing in front of Home Depot trying to get a day job, gardening or doing construction. Those are the people that this epidemic is hitting the hardest. And for them to lay out and go into quarantine or isolation, they need to have income support, or else they're not going to do it. And then the other lower risk workplaces are moving towards summer programs, maybe even starting the school year as early as July to catch people up, to ensure that students and staff are protected, basically rearranging classrooms with a lot of stuff about, should we do staggered schedules? Should some kids go Monday, Wednesday, Friday, and the others Tuesday, Thursday, Saturday? Should we do morning and afternoons? Should we just do the 11th and 12th grades together and the 9th and 10th grades together? There are a million options here, and I think we're going to have to kind of work through those. As we get the kids back in school, the broader workforce will be able to return to work. Now, I just wanted to say what we don't want to have happen. And you guys are used to wearing masks, and I'm going to hammer away at this. In 1918, so the 1918-1919 influenza pandemic started in the spring at Fort Riley, Kansas, which is now part of Leavenworth. And there was a outbreak in U.S. troops that spread across the Allied troops when these people went to Britain and France. It also spread into the Western European countries. It crossed the line into the German army, and then to the German and Austrian and Turkish populations. And soon it was a worldwide pandemic. It eventually, at a time when the population of the world was 1 billion, there may have been as many as 50 million deaths worldwide, and maybe as many as 500 million cases, with half the population infected. In the United States, it's estimated that there were up to 20 million cases. This is when the US population was 100 million, and 675,000 deaths. Different cities did different things. Much like today, the cities were kind of on their own for what they were going to do, and different cities did different things. San Francisco had a quite aggressive policy with closing lots of places where people would congregate, and also requiring people to wear masks, much like we're doing now. So there was a lot of kind of resentment, pushback about masks, and the ordinance really only stood for about a month, but it made a big dent in in transmission, and San Francisco ended up with about a third as many deaths as it had been projected. However, there was so much pushback about masks that they decided to get the Board of Health decided to rescind its ordinance about masks. And on November 21st, 1918, 10 days after the armistice that ended World War I, at noon, the sirens sounded, whistles blew through the city, and people threw their masks away. And the Chronicle says there was a sea of gauze on Market Street sidewalks. There were throw away your mask parties well into the wee hours, and within 3 months, there'd been 3,000 additional deaths. Remember what Dr. Louie said, there are currently 31 deaths in San Francisco. So 3,000 additional deaths in San Francisco. Okay? And I can show it to you here graphically. There was a long hiatus after this throw away your mask party with this increasing mortality. And in fact, they had to reintroduce masks and a lot of closures later to bring it back down. In St. Louis, often referred to as the best case scenario for flattening the curve, they did a pretty good job of it. They reduced it way down from the projected mortality, but let up for a very brief period of about 2 weeks, and they had a substantial rebound as well. Whereas Philadelphia, which did not a very good job, had much higher excess mortality and much higher overall mortality, but didn't have a second wave, largely because they'd probably exhausted the susceptible population. Again, this is for influenza A, where getting infected means that you're going to be immune, which is not necessarily the case with COVID. So this is a cry for wearing your mask. And I just thought I'd say 2 words about vaccine development. This is the life cycle of the virus over here. And the real kind of a key here is to block this, this attachment phase. I mean, there are a number of vaccines that look at a number of different things, but the protein-based vaccines basically putting out spike proteins, these little T things here, and creating antibody and raising antibodies to those, much like we do for hepatitis B, where it's hepatitis B surface antigen alone that we inject, and that raises antibodies to it. I think that's probably the most likely to come into play the soonest. And you can see that these are the numbers of vaccines in development. Okay, so I will stop there, and I'm happy to answer questions as well.
I think perhaps we're going to move on to Joe Forrester's talk first and then do questions at the end. If
Questions.
Cool.
All right, so Dr. Joseph Forrester is an assistant professor in acute care surgery at Stanford, as well as the associate trauma medical director and director of the new Center for Reconstruction After Chest Wall Injury. He completed his medical school training at the University of Virginia, followed by a general surgery residency and surgical critical care fellowship at Stanford. He also obtained a Master's of Science in Infectious Disease from the London School of Hygiene and Tropical Medicine, and was an Epidemic Intelligence Service Officer with the CDC from 2013 to 2015. He will share his insights on protecting the healthcare provider during an outbreak, lessons from Ebola applied to COVID.
All right, thank you. Are you able to see the slides?
Yes.
Excellent. All right, so I have no financial disclosures. The opinions I'm going to discuss are my own and don't necessarily represent any of the prior current organizations for which I've worked. So before I jump into COVID and Ebola, I want to discuss my background as I'll reference this experience throughout the rest of the talk. I was an Epidemic Intelligence Service Officer from 2013 to 2015 with the Centers for Disease Control and Prevention. For those who might not be familiar with what EIS is, it's a government entity created in 1951 in response to perceived biological weapons threats during the Korean War. The goal of this competitive two-year fellowship is to train disease detectives in applied and field epidemiology. During my fellowship, I was deployed to Liberia twice from July to August, and then again November to December of 2014 to assist the Liberian Ministry of Health with their Ebola response. Additionally, I participated in several domestic and international investigations into plague and tularemia outbreaks, which are 2 Tier 1 bioterrorism agents. So my recommendations about protecting healthcare workers in a pandemic will be based upon what I learned investigating clusters of infection among healthcare workers, assisting with hospital infection preparedness during these prior outbreaks, and what we've learned so far during the COVID-19 pandemic. So there's some certainties with any pandemic that I'm going to assume for the rest of the talk. People will continue to get sick from non-pandemic related pathology in addition to the burden of pandemic-associated disease. We must maintain our capacity to care for both infected and non-infected patients. And ensuring the safety of healthcare providers is absolutely essential to ensure that we can maintain the capacity to provide care, assuming that healthcare needs will only increase. So next I'm going to describe 2 investigations I performed in Liberia. These and other investigations serve as cautionary tales as we respond to COVID and helped inform several of the guidelines and protocols we developed at Stanford. So I'm going to begin with an investigation I performed on July 24th and 25th of 2014. Phoebe Hospital, located in Ballin County, Liberia, is located at the site of the Crimson Star on the map on the right. This facility was a 200-bed tertiary referral facility for the county and was one of the main hospitals treating patients who crossed the border from Guinea. Their first suspected Ebola case arrived on July 21st and was a patient who was not identified through ED triage and was admitted directly to the ward. Within 2 days, this patient died in the hospital. On the same day that the patient died, 4 of the 5 nurses caring for the patient fell ill. And within the next 4 days, all 4 of those nurses had died. Additionally, on July 24th, the day my investigation started, we were alerted that the physician who had cared for the patient tested positive, and the next day he had died. These healthcare worker infections set off a chain of transmission of at least 19 infections in the community over the following week. The effect on the healthcare system was chilling. On the day we arrived, the hospital had been completely abandoned overnight. All the patients and staff had fled the hospital and entered the community. This string of healthcare worker infections profoundly impacted how the community viewed the hospital and healthcare workers. In addition to all of the untreated medical and surgical conditions that were now no longer able to be treated in the hospital, hospital staff were both attacked and shunned by the community. There were reports of nurses being chased through the streets by residents chanting Ebola, and many feared for their personal safety. Ultimately, a months-long public health campaign in conjunction with county public health officials, religious leaders, and hospital staff was required to get the hospital back to basic functioning. The cautionary tale from this investigation is that when healthcare workers transmit infection or are infected themselves, there is a precipitous decline in a community's faith in the medical system. Outside of the threat to their own well-being, I believe that this is the reason it is absolutely critical that healthcare workers are adequately protected. They must be screened for infection, and they must not work if they're sick. My second cautionary tale began on July 28, 2014. I was informed by my team lead that 2 Americans, Kent Brantley and Nancy Wrightball, had become infected with Ebola over the last couple of days while I had been in Bowen County. These were the first 2 Westerners infected at this point, and they worked in an Ebola treatment unit, or ETU. There was an intense concern among many US political leaders and leaders representing non-governmental organizations working in the ETUs that the infections of Kent and Nancy meant that the virus had changed or mutated, that it had become airborne. Now, ELWA Hospital, where both Kent and Nancy worked, was a faith-based private hospital in Monrovia, the capital of Liberia. The hospital cared for 150 to 200 admitted patients per month. Over the last month and a half, ELWA had decided to open up an ETU inside of their existing hospital. In the figure on the right, you can see the general location of the ETU, located within the chapel, located in the fence perimeter of the hospital. Patients were triaged at the entrance to the hospital and then were directed to either the ETU or the ED based on their symptomatology. Notably, some staff, Kent and Nancy included, worked at both the ED and the Ebola treatment units. Staff shared facilities, including bathrooms, showers, and eating areas, and direct physical contact between staff was common. So on July 28, 2014, on a hot, humid, and overcast day in Liberia, Jerry Brown, the medical director for the hospital, the same Jerry Brown who was later on the cover of Time magazine, met me at the entrance to ELWA. We walked under the triage line and spent the day walking through the now abandoned hospital and ETU, retracing Kent and Nancy's daily routine, hunting for possible clues about opportunities for infection. In the middle image, you can see the front of the hospital where triage took place. In the image on the right, you can see the entrance to the makeshift ETU where Kent and Nancy worked. Our investigation identified 3 patients that were undetected by triage but infected with Ebola who ended up getting treated in the hospital ED. One of those patients died in the ED before they were able to be retriaged. We found that healthcare workers in the ETU actually did not report any unexpected exposure. They had systems in place to ensure that PPE use in the ETU was appropriate. Conversely, healthcare workers in the ED oftentimes provided direct patient care only with gloves, and oftentimes only when gloves were available. A lot of times, healthcare was provided with bare hands, no face shields, and no masks. Similarly, cleaners working in the ED used gloves and gowns but had no other form of mucous membrane protection. And we found that adherence to basic infection prevention concepts is often considerably less stringent outside of the highest risk environments, and that it is essential to create a system of accountability that will enable and enforce basic infection prevention throughout the healthcare system. When there is community transmission of a pathogen, it is absolutely essential to identify weak points in triage, invest in good triage, and ensure that healthcare workers are compliant with basic infection prevention outside of the highest risk settings. There is a tendency among healthcare workers to assume that triage is perfect, when in reality it's a fallible system. There are opportunities for infected but undetected patients to make it through triage. It is in this rare but potentially catastrophic situation that adherence to basic infection prevention concepts is paramount. So again, here are the 6 primary recommendations that I took from my investigations into healthcare workers infected with Ebola that I believe must be applied to COVID-19. Healthcare workers must be adequately protected with PPE and know how to use it. Healthcare workers must be screened for infection, and they must not work if they're ill. Leaders of the healthcare system must address weak points in triage and invest heavily in triage, including testing. And no matter how good triage becomes, there's always the chance that an infected but undetected patient makes it through. During a pandemic, it is essential to assure that there is compliance with basic infection prevention principles throughout the healthcare system, not just in the highest risk settings. Now, I'm going to describe briefly how we took some of these principles and turned them into actionable plans to protect healthcare workers here at Stanford. By mid-March, it was clear that we needed a way to ensure that we could continue to operate safely. Stanford established a multidisciplinary task force with leaders from across the interventional platform to come together and figure out a way to ensure that we could continue to care for our surgical patients. Leveraging my experience from the CDC, we developed an algorithm that ensured that healthcare workers were adequately protected. This, however, required heavy investment in testing capacity. At that time, we thankfully had an in-house RT-PCR test. What we did was stratify an operation according to the urgency of the operation, anticipated viral burden at the operative site, opportunity to aerosolize virus with a given operation, and potential for a patient to be infected. This algorithm allowed us to prioritize patients who needed an operation, rationally conserve PPE, and protect OR team members. Similarly, we identified weak spots in our triage, predominantly among patients presenting in extremis. This included incapacitated or obtunded trauma patients, stroke patients, or patients experiencing a medical code. The good news is that the PPE that every member of the trauma team should be wearing for COVID is nearly the same as what they should have been wearing pre-COVID. The healthcare worker on the left is wearing a gown, gloves, mask, and an N95 respirator, which is what the CDC recommends for healthcare workers caring for COVID patients. The healthcare worker on the right is wearing identical PPE with the exception of the mask, which is now a surgical mask. However, enforcing this PPE use was challenging, particularly when PPE was in short supply. To help structure our use of PPE in the trauma bay and rationally conserve PPE, we created the trauma PPE protocol that you can see on the screen on the right. We defined the minimum number of patients or personnel by trauma severity and developed a screening protocol for testing of trauma patients. However, placing these sheets was not enough. To get compliance with these protocols, this required frequent trauma audits by myself and one of the ED nurses, particularly early on in the response. Again, what we were asking of our trauma care providers was not new. It is in line with standard infection prevention guidelines. However, it took reinforcement of these standard infection prevention practices to ensure compliance. So my goal has been to provide you some recommendations on how to protect healthcare workers based on my experience with Ebola. Healthcare workers must be protected, which includes access to PPE and the knowledge of how to use it correctly. Healthcare workers should be screened for infection and should not come to work if sick. The consequences of having chains of transmission that originate from the hospital is a collapsed healthcare system. It is critical to identify weak points in triage and then invest heavily in improving triage. Finally, during a pandemic, it is essential to ensure compliance not just in the highest risk situations, but throughout all interactions within the healthcare system in the unlikely event that a patient is not triaged appropriately. And thank you again to Mark, Julia, and the San Francisco Surgical, and I'd be happy to answer any questions.
Joe, thank you so much, and thank you to all of our panelists. Such great presentations and a wealth of information. So we'll start off with the Q&A, and anyone who feels comfortable answering the question, please chime in. The first question is from Dr. John.
I'm gonna unmute all the panelists and put their video on, if that's just to let them know. So go ahead.
So John Rapkin is asking, any insight into allowing resumption of elective surgery in San Francisco?
Can you say it again, please, Julia?
Yeah, any insights into us allowing the resumption of elective surgery?
I can tell you, me being a in pediatric infectious diseases and tropical medicine and a former EIS officer too, I'll have you know, from 82 to 84, that I've been roped into these discussions at UCSF, and we've gone back to having elective surgery. I don't know if it's all the way fully up and running, but if it isn't, it's going to be very quickly. But we're trying to fill the hospitals back up, and we've had, right now I think we probably have, I would say maybe 15, 16, 17 COVID patients as inpatients, maybe a little bit more than half of those in the ICUs, and we think we have plenty of capacity. So yes, we're moving forward.
So in the question section, Dr. Gerald Zyderak has asked if there's any studies on the medications going on locally, like hydrochloroquine or zithromycin. And what's the data? What do you guys think the data is on that?
Oh, George, do you want to answer, or?
Yeah, well, we're certainly studying remdesivir, and there's still some trial protocols going on. There are continuing protocols for hydroxychloroquine. The azithromycin hydroxychloroquine combination, it really has really a big problem with prolonged QT intervals, and so those have been pretty much pushed back off the kind of the study framework. But we're studying not only those things, but a whole number of well, also additional antiviral drugs, but also things to interrupt the cascade of the inflammatory cascade that leads to ARDS.
All right. Great.
So the big thing out of the box is remdesivir. Remdesivir is an general antiviral drug, originally developed for Ebola. It didn't work for Ebola. Using it for patients who are hospitalized with sort of moderate to severe disease, it reduces the length of stay from 15 to 11 days and the mortality rate from 11% to 8%. I think that's right, Janice. If you jump in if you know the numbers better than that.
I haven't seen the mortality numbers yet, so.
And it was a trial that was ended early, which is always sort of, worrisome.
Thank you. Michael Wood is asking, when, in your opinion, will international travel be safe again?
Well, it depends on where you want to go. If you want to go to Vancouver, we can probably do that pretty quickly. I think we're probably talking fall, if then. Italy said they're not going to open their borders until like April or March or April next year, just to give you an idea of what one country's doing. But I think it would probably be, if things keep going the way they're going here, and we don't have a big spike in the fall, which is quite possible, I think we might be able to travel again in the fall. And for you tennis fans, the French Open has been rescheduled for October, by the way.
All right, Dr. Kolchak from Stanford is asking about, I think, the relative differences between San Francisco and LA, and why San Francisco is so much more successful, and which of the contributions was it? Public transportation? Was it the lockdown order earlier? Easier to work, a larger proportion of our businesses are work from home, weather?
Yeah. Well, I don't know about weather. Yeah, it's cold all the time. I think the big the take home for the initial phase. I mean, once these things start, they're very hard to stop, and these things steamroll, and you get more and more transmission and more chains of transmission, as you see in New York. And it kind of doesn't matter what you do after a certain point in time, the epidemic's going to continue to grow. I think what we saw in Los Angeles was they went somewhat later to shelter in place. They took it somewhat more casually, at least for the first couple of days. And that sort of 6-day difference created the original kind of rise in cases relative to San Francisco. It started to come down, and then it got away from them, quite frankly. And it's you're seeing these large outbreaks in the homeless especially, and in a number of communities around Los Angeles. The Los Angeles Times actually has a really great page on COVID-19 with shows where all the cases are, not like addresses, but it puts dots on the map, and it's pretty much spread. It's not out in the valley. It's not way up north. It's pretty much spread through the middle of the city.
What's interesting, sorry, go ahead, Janice.
I think LA is so much bigger. I mean, we're 800,000 and LA is 12, 13 million people. It's very hard to tamp down transmission in that huge of a population.
Yeah, but I think for the other thing to remember is that in rare diseases, and this is a rare disease, the prevalence in San Francisco is I would be amazed if it's above 1%. Even in the most high-risk census tracts in the Mission, in a study that Dr. Diane Havler just completed, it was 1.4%. And there's more data to come, and that's very preliminary and all that. But it's still, I mean, I would be amazed if it's above 1%. So you really treat this as a rare disease. And in rare diseases, the numerators are as important as the proportions. So, low transmission means low transmission. And high transmission means high transmission. And it sort of doesn't really matter what the underlying population structure is. If you do New York versus Los Angeles, It looks exactly the same as San Francisco versus Los Angeles. There's very little in Los Angeles and a ton in New York.
Great. Dr. Shelley Marks is asking if you have any comments on Sweden, on their sort of handling of the lockdown and their evolution of COVID cases. If you have any comments on that.
This is for me again. And so Sweden went down a different road. They decided that they were going to put in place very modest precautions, basically asking people to keep social distance, and that was about it. And they didn't close anything, and they sort of took the mortality. The problem is that when you compare it to Norway, the mortality rate, at least the last time I looked, was 6-fold higher. There was a very favorable article in the New York Times where they didn't really talk about comparative mortality with the other Scandinavian countries. That kept talking about comparative mortality with Ireland, which is, sort of different. So I'm not, it's an interesting experiment. I look forward to seeing it published with a real comparator like Denmark or Norway. And at least for a while, it looked like it would have gone really badly off. The New York Times article makes me want to take a step back and relook at it again. But I think, the generalized, it's kind of the generalizable bit of knowledge from this is that at least when the last time I looked, that while they may have had relatively low counts, they had significantly more mortality.
Can I add, George, that I think the idea is obviously we want to flatten the curve and we want to not overwhelm our hospital systems. But we also, I think we do want to support some level of herd immunity in the population. And I wonder if San Francisco has suppressed too much, because I think eventually we are flattening the curve, but we may see a second wave that's pretty bad. And at least if you use the correlate of influenza, as an ID person, what you have is cumulative immunity from exposure to multiple different subtypes, which may be protective.
Yeah.
So it's not 100%, but your clinical severity may be lessened the more you're exposed. And I wonder if that's the same for this virus. And, I'm just not sure as we relieve shelter in place, if we are not going to see a huge explosion because we don't have a lot of herd immunity in San Francisco.
Well, I would also point out, Janice, that the herd immunity in Wuhan, there are probably only 2% of the population of Wuhan is seropositive, and maybe 4% of northern Italy. So even in places where it's gotten wildly out of control, and with tens of thousands of cases, they really still don't have anything approaching herd immunity. And even if we could measure neutralizing antibody and say who's immune from what, I don't disagree with you that the proportion of the population that is immune is very low here, but I don't know of any place it's not very low. Even New York, even the most sort of extreme projection for New York was around 13%, which I think is probably way high. Nobody's getting that close to anything approaching herd immunity.
There was a second part to that question that had to deal with your best guess as to whether schools are going to be open and operating next year without any disruption. What are the chances of that?
And
Good, Janet,
professional sports too. But
Yeah,
another question about professional.
sports. Go ahead, you guys. You have skin in this game. You're young enough.
You're a pediatrician. I think that's a really hard one.
Okay, I can answer the pediatric.
I mean, I do feel like I'm interested in what you have to say. I'm glad this is an open discussion because I'm learning a lot about why you think transmission in children is not going to be an important source, because I think they are shedders of every other virus. So why not this virus?
So I'm not committed to that.
Okay.
By the way, Janice, I think it's kind of an open question, but I don't think it's automatically the same as influenza. And the evidence for that is it's very sparse. The evidence is very thin about children being big shedders. In Iceland, now we're drawing all our great studies from Iceland. In Iceland, they did a national probability sample and enrolled 848 kids under 9 and under. 0 of 848 were positive by nasal pharyngeal and oral pharyngeal swabs. That's, which I found really surprising, because they're going to be locked in all winter, right? It's like being out in the avenues in August. It's like freezing cold, and they're going to be inside their houses all the time. The other thing is there was at least one outbreak in France where they went through something like 112, 113 students to try and find people who might have been exposed to a kid who got infected by his family, and they found 2 positives. So it doesn't seem to be huge. And there's been an outbreak in high schools in France with a lot of transmission. We know of a lot of pediatric cases. We have this weird Kawasaki syndrome kind of thing now, which I think maybe have been masked COVID virus infection or COVID infection or SARS-CoV-2 infection. But I don't know that it's an absolute given that schools are going to be the hotbeds of transmission that they clearly are for influenza A. To be determined. I got a note from some guy. He was a second grade teacher in San Mateo County, and he said there was some weird disease that went through the classroom. And I said, oh man, this is a good one to study, because this might actually represent an outbreak in a school, which would say, okay, the influenza A models are correct. But I think it's kind of an open question now. There's data on both sides of it. Having said all that, this is the Pollyanna version. Having said all that, of course, the schools are going to be completely different in the fall, because they're going to have to try and cohort students together to try and decrease transmission. You might see morning and afternoons. You might see Monday, Wednesday, Friday for certain classes, and Tuesday, Thursday, Saturday for other classes. The classrooms are going to be rearranged to push the desks apart farther. There's going to be a lot of stuff. They're going to try and cut down the mixing as much as possible. And if you have a middle school, if you could do it, if you could cut the classes up into, the students up into 4 groups and keep them separate from each other, that would be almost ideal. So if there's an outbreak, it doesn't spread through the entire population, but is kind of confined to a quarter of the population or half the population, or however it works out. I think you're going to see a lot of experimentation with this during the summertime to try and figure it out. And remember, in schools, we have a pretty quick indicator, which is absenteeism, for how well it's working.
Right. 2-part question, partly from Dr. Stanton in the East Bay. This may be for Joe Forrester. He's asking if all physicians and healthcare workers at the hospital should be tested. And as a follow-up to that, I'm curious, are there reports in the Bay Area of any hospital transmissions? It seems like in healthcare facilities, there's been a big problem, and obviously the SNFs and the elderly care facilities, but it doesn't seem to be a bigger problem in the hospitals, and maybe they're following your advice already, Joe.
Yeah, so with respect to the former part of the question, do I think healthcare providers should be tested? Yes, I do think they should. The question really is, what frequency should that occur at? I think the challenge is, I'll be on service and see 50 patients in a day, and if I'm infected and shedding virus and not taking appropriate precautions, like that could be a lot of people who are potentially exposed. So, in my mind, it seems like a low-hanging fruit to make sure that your healthcare providers aren't exposed or aren't infected and shedding virus. And then to the latter part of the question, I guess I would defer that a little bit to George and Janice. From the data you presented, it doesn't seem like there are many healthcare-associated outbreaks outside of the nursing homes, but I would defer to you guys.
I think there's San Francisco data that it's, George, I'm sure you know this better, it's around 5% of all of our known infections, but again, our testing is very skewed. So, until we have universal testing, including of asymptomatics, which I just saw that San Francisco General Hospital is now testing everyone who enters the ER. And as you know, San Francisco is offering pre-testing and recommending testing for all essential workers, even asymptomatic. I think we'll get a better picture of what's
But
happening.
just to be clear, do you think 5% of transmissions were within hospitals, or
Well, I mean, I
are
think
community
that's,
acquired?
yes, that's the unknown, right? I don't think you can know because everyone's going home. They're interacting with other people who may be infected. I think it's very hard to tell when you have a proportion of transmission that is asymptomatic.
So Stanford just got through screening everybody, right?
Mhm.
And it was 0.3%. Do I have that number correct?
Yeah, it's
It's
very
quite
low.
low.
Yeah.
Of course, we have never had, we've planned for a lot more patients than ever came in. Very, very small numbers. Yep. All right.
All right.
Do you have another one there, Yulia?
Yeah.
Why don't we do 2 more questions and then we'll wrap it up? It's getting a little bit late.
Sure. So Dr. Jim Kordendorfer has a 2-part question. One is, how much do masks
Why is all
matter?
these hard questions? Huh?
And then the second question is, why is this virus not going to burn out like SARS, MERS, Ebola, et cetera?
Okay, why do I get all the questions here?
Cool.
Okay, so I'll answer the second question. First of all, Ebola doesn't burn out. It's there. It continues to crop up. It's a zoonotic disease, probably passed from bats. We blame everything on bats in our world. And it's endemic in bat populations, and it will continue to crop up in Central Africa from now until forever, until we get some sort of a veterinary vaccine for it that you can drop from the air and the bats will like to eat, which is how you have to do these kinds of wildlife vaccines. I think that MERS has really not gone away either, and that continues to crop up. SARS went away because of very deliberate efforts to suppress it. The thing to remember about SARS and MERS is that they're really nosocomially transmitted disease, and it's really from instrumenting the lower respiratory tract that most of the exposure occurs from aerosols and stuff. And yes, there's some fomite transmission, and yes, there's droplet transmission, but the real big clusters of SARS and MERS, with a couple of exceptions, have really been in ICUs. And ORs and places like that. So that's what those are. So SARS has been deliberately gotten rid of, at least until it crops up again. MERS is continuing to emerge. This virus, I think, will continue to. I think we've missed the chance to eradicate it, and I think it'll be with us for quite a while, and until we can get the vaccines in place and get everybody vaccinated. And even then, it'll probably still circulate.
I agree. I think the studies have shown that the viremia is really highest in the early parts of the illness, and definitely there's a lot more concentration in the upper respiratory tract than with SARS and MERS.
Yeah.
And as far as the effect of masks sort of worn in the community, not in a healthcare setting, how much do those actually matter?
You want to give the party line, Janice, or shall I?
No, go ahead.
A lot. Right. Bottom line.
Yeah.
A lot. Now, I'm kind of toying with the notion of saying that muni drivers should be given N95s. We have essential workers who get exposed over and over and over again, and we've given them this sort of kind of surgical masks, do-it-yourself sort of things, which are meant to prevent them from transmitting to other people, which is a perfectly legitimate use. But I think for people who are coming into constant contact with the public, especially people who work for the government, we should be giving them N95s. It's not currently policy, by the way.
I think one of the benefits of having people masked in public too is it just helps remind everyone that we're taking precautions. And so, not touching your face, washing your hands, it just provides that constant reminder that you need to be taking basic infection prevention seriously.
And I also don't think we can discount the role of fomite transmission. I think that's also a very important component that is not quite clear what it contributes, but I suspect it's significant.
Yeah, I agree.
All right. How about 2 quick answers? can we believe the numbers coming out of China from Dr. Rabkin in terms of their mortality numbers and infection rates? And then, yeah, one more question after that.
That's a George question.
Yeah.
I think you can believe the morbidity numbers. Mortality might be a bit obfuscated, but it's I think that certainly the shape of the curve and the numbers of cases seem quite credible. Plus, WHO is looking over their shoulders. As much as the administration hates WHO or likes to blame WHO for things, they're actually highly competent on many things, including this. So I'm somewhat, I feel pretty good about WHO's estimates of the number of new cases. Deaths are another issue because people can die anywhere, and that becomes a complicated counting problem.
Okay. Let's see. Well, it's 8:30 now. I think the extensive questions indicated what great talks you guys all gave. I really appreciate it. Wednesday evening for an hour and a half. And I'm sure this is not the first Zoom meeting of the day for you all. So thank you so much for participating. So I think we're going to move on to business meeting.